Hello, everybody. Good afternoon. Thank you for joining our webinar on Medicaid Unwinding. My name is Jomia. I'm the Public Policy Manager at the National Council of Urban Indian Health, also known as NCUIH. And joining me from the NCUIH team is Rori Collins, our Public Policy Counsel, Evelina Maho, our Director of Technical, and Evelina Maho, our Director of Technical Assistance. We kindly ask that you guys place your name, your UIO, and your title into the chat box. And like we mentioned before, if you signed into here named Amy Lord, you can go ahead and change your name on the screen as well. So just a little bit about NCUIH and a little bit background on us if you guys don't know. We're a national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent healthcare and public health services that help to serve American Indians and Alaska Natives living in urban areas. Before we begin, just a little bit of housekeeping items. This webinar will be recorded and will be made available for public viewing. All mics have been muted. If you have any questions during the presentation, feel free to drop them in the chat box. We'll have some time at the end for Q&A. And in addition, we welcome any feedback you'd like to provide about your webinar experience through this survey. So there's a QR code on the screen here. You can scan and take our survey. Also drop the link in the chat after the presentation, and we'll also follow up via email. So this is our agenda for the webinar today. First, Rori will give an overview of Medicaid Unwinding, some updates on changes, and some best practices for UIOs. And then I'll talk a little bit about the work and advocacy we've been doing with partners around the unwinding. And then after that, Evie will provide information about the marketplace open enrollment and what UIOs need to know. Then we'll open up the floor for Q&A. So now I'll pass it off to Rori to get us started.
Thank you, Mary. Hi, everyone. My name is Rori Collins. I am Tanana Athabascan, a member of Nenana Native Village, and I am Public Policy Counsel here at NCUIH. So I'm going to try to give you guys a lot of information about the Medicaid Unwinding and updates about it in a short amount of time. So first, before I get into the unwinding, I just want to quickly talk about the impact of Medicaid on Native people and UIOs and why all of this matters. So Medicaid is a joint federal and state program that provides health insurance to eligible persons, including eligible Native persons. And inadequate health insurance coverage is a significant barrier to healthcare and can cause patients to delay or avoid medical care altogether, and exacerbates significant healthcare disparities faced by Native communities. And so, as you can see from the numbers on the screen, Medicaid provides critically important coverage to a large number of Native and specifically urban Native people. So looking at the importance of Medicaid for UIOs, in 2021, 55% of the total UIO patient population and 46% of the American Indian and Alaska Native UIO patient population were Medicaid beneficiaries. And so because of this, Medicaid serves as a critical source of supplemental funding for UIOs who have been chronically underfunded by the federal appropriations process historically. And in fact, Medicaid is one of the largest secondary sources of funding for UIOs outside of IHS. And because Medicaid programs are mandatory and aren't subject to the annual appropriations process, Medicaid revenue is particularly essential because it still remains available during government shutdown periods and budgetary disagreements. So now for just a quick overview of Medicaid Unwinding and the public health emergency. So for the background of the Medicaid continuous coverage flexibilities during the public health emergencies. So the continuous coverage flexibilities were put in place in response to the COVID-19 public health emergency or PHE. And so in March 2020, the Families First Coronavirus Response Act required state Medicaid and Children's Health Insurance programs or CHIP programs in exchange for enhanced federal funding to keep beneficiaries continuously enrolled throughout the end of the COVID-19 public health emergency or PHE. And this meant that states couldn't disenroll Medicaid beneficiaries, so it allowed Medicaid beneficiaries to retain their coverage and receive needed care throughout the public health emergency without having to worry about maintaining coverage. But in December 2022, the Consolidated Appropriations Act of 2023 was signed into law, which separated the continuous coverage provision from the COVID-19 PHE and set an end date for the continuous coverage period at March 31st, 2023. And so this meant that states could resume reviewing Medicaid eligibility for beneficiaries and for their coverage, and begin disenrolling beneficiaries who didn't meet program criteria on April 1st, 2023, which was a process referred to as unwinding. States have up to 12 months to initiate and 14 months to complete the unwinding process. So the projected end date for this entire unwinding period is June 30th, 2024. And unwinding will be the largest health insurance transition in the history of the United States, and many beneficiaries in underserved communities, like Native communities, are at a significant risk of loss of coverage. But one thing to note is that the Consolidated Appropriations Act gave CMS the authority to take enforcement actions against states that don't fulfill all the federal requirements applicable to Medicaid redeterminations in an effort to keep people covered. And so with these authorities provided by the Consolidated Appropriations Act, CMS can require corrective action plans, reduce the state's federal matching rates, or impose civil monetary penalties, or place procedural terminations on hold pending corrective actions for states who aren't following these federal requirements in the unwinding process. And so the unwinding poses several barriers for beneficiaries and states. During the unwinding, millions of eligible families are at risk of losing coverage due to administrative barriers and procedural reasons, even though they may still be eligible for Medicaid coverage. And Medicaid eligible Native people face unique challenges during this redetermination period due to some specific factors like geographic remoteness or limited access to phone or internet service, cultural factors, lack of knowledge of benefits of coverage or movement between non-reservation and reservation land. But luckily, some states have eliminated some of the red tape during this process and paperwork requirements for beneficiaries by using available data to establish eligibility rather than having people fill out forms for the redetermination process. But regardless, disenrollment of eligible Native people from Medicaid and CHIP will have significant consequences for the health and well-being of Native beneficiaries, particularly given the importance of these programs for healthcare coverage, and then for fulfilling the United States Trust responsibility to maintain and improve the healthcare of Native people. And so I just want to give one sort of specific example about a redetermination barrier, the eligibility systems issue. So one example of a barrier to redetermination is a state system issue that happened this past August. States have to use existing data sources to confirm eligibility on an individual basis and conduct automatic or ex parte renewals, meaning that if a state can determine that an individual is still eligible through existing data, as I said before, beneficiaries should automatically retain their coverage without having to complete and return a renewal form. And states can send a renewal form to individual beneficiaries only after they have done their ex parte process. And CMS found that eligibility systems in a number of states were operating with an error in conducting ex parte renewals at the family level rather than the individual level. And so even though individuals in a family may have different eligibility requirements, to qualify for Medicaid and CHIP. And so states were incorrectly sending renewal forms to a family, were not sending a renewal form to a family unless every single person in that family was found eligible under the ex parte process, which is against a CMS regulation. And because of this specific glitch, around 500,000 individuals were improperly disenrolled from their Medicaid and CHIP coverage. And CMS directed all states to determine whether they have an eligibility system issue that could cause eligible people to lose their Medicaid or CHIP, and required them to immediately reinstate coverage for those wrongfully disenrolled. The glitch affected people in 29 states and the District of Columbia, and CMS required them to pause procedural determinations for the impacted people unless they could ensure all eligible people are not improperly disenrolled due to this issue and fix their systems. And so I'm going to shift the topic a bit to data around the unwinding and just give an overview of some of the data that's publicly available right now. So the 2023 Consolidated Appropriations Act requires state monthly reporting about activities related to eligibility renewals, call center operations, and transitions to marketplace coverage from April 1st, 2023 through June 30th, 2024. And CMS has released 3 batches of the required state data reporting metrics, and most recently in September, but CMS generally releases data 3 to 4 months after receiving it. Many states have also decided to publish their own data dashboards. The Georgetown Center for Children and Families has a Medicaid Unwinding tracker, which is updated using state monthly data reports to CMS. And Georgetown also analyzes renewal data based on renewals completed, and disenrollments. Additionally, KFF has an unwinding tracker which uses both state monthly data reports to CMS and state data dashboards and shows real-time data similar to Georgetown and CCF. This tracker shows recent data disenrollments, renewals, overall enrollment, and other key indicators reported by states during the unwinding of the Medicaid continuous enrollment provision. But unfortunately, very few states report unwinding results that are disaggregated by race and ethnicity. And so as a result, it's quite difficult to determine with specificity how many American Indian Alaska Natives have lost Medicaid coverage. And this is an issue that NCUIH and partner organizations have been working to address, and Mary will touch on this a little bit later. So I'm just going to go into the numbers quickly. So according to KFF, about 11.8 million Medicaid enrollees have been disenrolled as of November 21st, 2023, based on the most current data from all 50 states in the District of Columbia. And of those disenrolled, 71% or 8.3 million people have had their coverage terminated for procedural reasons. And this means that 7 in every 10 people terminated from Medicaid may have been eligible, but lost coverage due to administrative or paperwork issues, such as not having updated contact information and not turning in a form that was mailed to them. So more people have lost Medicaid during these first 6 to 7 months of the unwinding than any 2-year period in the American history. And so for best practices, I know I've really just thrown a ton of information at you, but I just want to suggest some best practices for UIOs to assist your patients with their coverage, such as working with your state, tribes, federal agency, and community. UIOs play an important role in enrolling patients in Medicaid and CHIP, as well as treating Medicaid beneficiaries, and we recognize your efforts to keep patients covered. And so one of the best practices is working with tribes. UIOs can collaborate with tribes to request a meeting with your state regarding unwinding and develop partnerships with tribes to provide necessary information to Native beneficiaries. UIOs can also work with federal agencies like CMS and IHS to request consultation and confer with the agencies to discuss concerns. Culturally appropriate materials such as toolkits and graphics for tribal enrollment assisters and those assisting Native people with their coverage have been developed by Agencies and partners like the National Indian Health Board and all are available for you to use. And UIOs are well positioned to reach urban Native people and can really work with your communities to keep people covered. UIOs may have access to more beneficiary contact information and can share updated information with state Medicaid offices. And since UIOs work directly with beneficiaries, you can remind them to renew and offer assistance with completing the renewal process through your enrollment specialists. And you can also engage community partners, health plans, and the provider community to encourage individuals to update their contact information and provide assistance with renewals. And finally, educating patients about the unwinding and the risk of loss in coverage by providing outreach and educational materials in clinic waiting rooms, patient rooms, and patient registration decks. And then state flexibilities. Another best practice is to work with your state by advocating that your state apply for a Section 1902 E14A waiver, also known as an E14 waiver, if necessary and applicable. The Section 1902 E14A of the Social Security Act allows for waivers as are necessary to ensure that states establish income and eligibility determination systems that protect beneficiaries. And these waivers are time limited and meant to promote enrollment and retention of eligible individuals by easing administrative burdens that states may experience. And so this slideshow shows the different flexibilities allowed for states to make renewals easier, outlined in a March 2022 state health official letter from CMS. And states may also request E14 waivers to implement other strategies to address challenges during the unwinding. So strategies that got approved are using National Change of Address or USPS to update beneficiary contact information and extending the time frame for automatic re-enrollment into NCO plans. You can also work with your states by requesting that your state share renewal data via spreadsheet or database so that you can speak with beneficiaries who utilize your services. In January 2023, CMS released communications to states and a state health official letter, number 23002, encouraging states to share data with ITUs to help with updated contact information for Native Medicaid beneficiaries. Indian healthcare providers can share updated beneficiary contact information with the state. And with monthly renewal data, UIOs can target beneficiaries who are at risk for lapsing coverage due to the unwinding. And so according to CMS, Arizona, Colorado, Idaho, Minnesota, Montana, Nevada, Oklahoma, and Oregon are the states currently working with ITUs by sharing data. And then just the last thing, I just want to highlight some of the resources available for Indian healthcare providers on unwinding. NCUIH developed a toolkit for UIOs last year that outlines the background of the unwinding and practices I shared with you today. The National Indian Health Board, in partnership with IHS, also developed a comprehensive toolkit for tribal enrollment assisters. CMS has also released a toolkit with Native-specific graphics. And you can work with your state to develop targeted communications for Native communities about the state's unwinding activities. And so that concludes my portion, and I'll pass it back to Mary to talk about partnership efforts.
Thank you, Rori. And as she just said, I'm going to talk about our partnership. I'm just going to breeze through my slides here. We've been quite busy these past few months advocating with other organizations to protect vulnerable populations from unwinding and Medicaid terminations. Here at NCUIH, we participate in coalitions and groups working on Medicaid issues such as the CMS Tribal Technical Advisory Group, also known as CMS TTAG, the Partnership for Medicaid, and a Medicaid Unwinding working group comprised of different organizations and civil rights and health equity groups working on this issue. So through these partnerships, we've been able to, be in several meetings with Congress, work on letters, conduct outreach, all about Medicaid unwinding. And I'm going to go into these efforts a little more in depth here. So with the CMS T-Tag, they provide advice and input to CMS on policy and program issues impacting American Indians and Alaska Natives served by CMS programs. NCUIH is a member of the T-Tag, where our board president-elect, Walter Murillo, serves as a representative of UIOs. NCUIH staff also serves as technical advisors to the T-Tag. So as a member of this group, we regularly attend the T-Tag Medicaid Unwinding subcommittee meetings. And then the toolkit that we developed that Rori mentioned earlier was circulated by the T-Tag group. And then earlier this year, we worked with T-Tag tribal leaders at their face-to-face meeting with CMS to request tribal consultation and urban confer on the unwinding. And then also as a member of T-Tag, NCUIH worked with the advisory group at their most recent October face-to-face meeting with CMS to request that states provide disaggregated data that shows how American Indians and Alaska Natives are being affected by the unwinding. Also want to highlight our work with the Partnership for Medicaid. We're also a member of this group. It's a nonpartisan nationwide coalition of 24 organizations representing clinicians, healthcare providers, safety net health plans, and counties. Around the time when the debt ceiling bill was being negotiated this past May, we joined the partnership in a letter to House and Senate leadership opposing broad-based work requirements as a mandatory condition for Medicaid eligibility, which was being pushed by the House. And in the letter, we emphasized that especially at a time when the Medicaid program is unwinding, work requirements are an additional burden for enrollees and the state systems that must implement them. And our specific concern in that letter is that the Medicaid unwinding process combined with the work requirements under consideration in the debt ceiling bill at the time will definitely limit access to health services and strain the capacity of Medicaid safety net providers already dealing with the unwinding. And, with this partnership, we meet monthly and we continue to learn and engage in the conversation of Medicaid unwinding in those meetings. We also actively participate in a civil rights and health equity working group on the unwinding of Medicaid. Back in April, we joined that group in leading a sign-on letter to HHS, urging the administration to use the authorities that were offered in the Consolidated Appropriations Act to protect people and families from losing CHIP and Medicaid coverage during the unwinding, and over 200 organizations signed on to that. We've been, through this group requesting CMS use its full enforcement authority when it comes to Medicaid unwinding. We've also been holding meetings as a group with the White House, with CMS leadership, members of Congress about the unwinding and to express our concerns. Our most recent partnership efforts with this group includes our work on a report about the first 6 months of the unwinding and the impacts of Medicaid terminations. We released this on November 6th. It estimates the disproportionate impact of Medicaid coverage loss on vulnerable groups like children, people of color, and American Indians and Alaska Natives. And the report calls on states to dramatically reduce procedural disenrollments by using reliable data to renew eligible families' coverage and connecting Medicaid families with trained personnel who can complete all paperwork needed to determine eligibility. You'll find in the report some estimates and figures about Medicaid enrollment and termination trends using data sources that Rori mentioned before, and the work group's own calculations to estimate race and ethnicity data. All of the data in the report was calculated based on what data was available during the first 6 months of the unwinding. And like Rori had mentioned before, there's a lack of disaggregated data by race and ethnicity, which has made it difficult to exactly see the impact of the unwinding on certain communities. Few states included in KFF's analyses report unwinding disaggregated by race and ethnicity, but in those states, the proportion of people of color among terminated beneficiaries is generally comparable to their overall representation among Medicaid beneficiaries. So this report uses those results as a general guide and estimates the distribution of unwinding terminations in each state based on demographic characteristics of the state's Medicaid beneficiaries, according to NCUIH's analysis of American Communities Survey 2021 data. Under these calculations, it's estimated that people of color comprise at least 5.4 million out of the 10 million people who have lost Medicaid, who have lost their coverage during that first 6 months of the unwinding, and this includes around 420,000 American Indians and Alaska Natives. But of course, these are just estimates, and the actual termination might not mirror the demographic proportions of each state's beneficiary population. This table here is also based on KFF data. It shows how much the data differs among states. At the time of the report, 10 of the states with the lowest disenrollment rates, the median rate of that was 20% of disenrollments, and by contrast, 58% was the median disenrollment rate for the 10 highest states. UIOs are located in 6 out of the 10 states with the highest termination rates, which are Texas, Montana, South Dakota, Utah, Wisconsin, and Oklahoma, as you can see on the chart here. And just to wrap up about why advocacy is important, I want to highlight what this advocacy has resulted in. And the administration is hearing our request. Through TTAC's advocacy, CMS began encouraging data sharing with states and ITUs to help with updated contact information for Native Medicaid beneficiaries. CMS also started releasing quicker preliminary unwinding data, which has been one of our requests. CMS is advising that Medicaid Managed Care Organizations, or MCOs, should be able to collect electronic and telephonic signatures from Medicaid beneficiaries and relay them to the Medicaid program for renewals, and just to make the process easier on the beneficiary. The debt limit bill that I was discussing earlier was signed into law in June, and it did not include new work requirements for Medicaid, another thing we were advocating for. And yeah, that includes my partnership updates. I'll pass it over to Evie to talk about open enrollment and the marketplace now.
Thank you, Mary. The next set of slides will provide an overview of open enrollment and the transition to ways to reduce gaps in coverages during the unwinding period for UIOs. The marketplace is available, and it provides a space where clients and patients are able to receive health plan, the ability to shop and enroll for services for individuals and families, and that's usually referred to the individual marketplace, as well as like for employees, small businesses, and also through websites. This is available through website, call centers, and in-person centers. The marketplace is where eligibility is determined for coverage plans. If folks are eligible for advance payments of the premium tax credit towards monthly premiums, if they're eligible for cost sharing reductions to lower consumer pay out-of-pocket costs like deductibles, co-payments, and co-insurance. Also to see if there's Medicaid and children insurance program eligibility. The marketplace also should be understood that it can be operated by a state or a federal government. And the key differences between the marketplace include the state-based marketplace, there's federally facilitated marketplace, and state marketplace federal platforms. The next slide really focuses, it displays that there's a bronze level, silver, and gold and platinum plan categories. And we'll note that health plan coverages or categories are really based on how you and your plan split the cost of your health care. And just note also, in addition to this, it doesn't, there's no correlation to the quality of care. As you can see here, the bronze, basically the insurance company is paying 60%, and the patient would pay 40% of the cost. You look at the silver, it's at 70% and 30% out of pocket. Gold at 80%. The insurance company pays, and 20% out of pocket. And then at the platinum level, the insurance coverage will pay 90%, and the out-of-pocket cost would be 10%. Okay. And so I wanted to briefly just to show this important slide here, in that many American Indians, Alaska Native, currently receive healthcare from IHS care providers. which include programs operated by IHS tribes, tribal organizations, and urban Indian organizations. And these health programs are sometimes collectively referred to ITUs, and American Indian Alaskan Natives typically don't pay premiums for ITU services and are only charged under limited circumstances to services provided by ITU facilities. This background information is important to be aware of as a healthcare organization. As we all are aware, in the U.S., tribal nations have government relationship with federally recognized tribes in Alaska, Native, regional, and village corporations. And for this reason, there are certain protections in Medicaid, CHIP, and the marketplaces. These protections apply to different categories of American Indians to the marketplace. Certain protections apply to a federally recognized Indian tribe or shareholders in Alaska Native Claims Settlement Act and Corporation. For Medicaid, certain protections apply to members of the federally recognized Indian tribe, NCUIH shareholders, or other individuals eligible to receive services from IHS. And CHIP, premium and cost sharing protections, apply to members of a federally recognized Indian tribe or shareholders in an NCUIH corporation. At the conclusion of my section of the talk, I will drop the link to you have access to those federally recognized tribal nations and what type of protections they might have. Even though American Indians can generally receive services from any of these Indian healthcare provider, regardless of whether they enroll in private insurance or through the marketplace, there may be some advantages for them enrolling in the marketplace coverage, and they might be eligible for advance payments of the premium tax credit or cost sharing reductions. So marketplace enrollment may help to ensure access to a wider range of providers and services while not impacting the American Indian Alaska Natives eligibility for the healthcare services through the current IHS Indian healthcare system in the United States. The Affordability Care Program Premium Tax Credit. Basically, these are available for consumers with certain household incomes who aren't eligible for qualifying coverage, like a job or Medicare or most Medicaid coverage or CHIP may be eligible for saving through this marketplace. If we could continue on to the next slide, I want to make emphasis that the amount of the premium tax is a consumer is eligible for may change throughout the year. So the important thing to remind folks on this call with this particular slide is that any time the consumer's household income changes, the size or other determining factors, it's really important that these are reported right away. So that it's any of these life changes should be reported to the marketplace. We can move into the next slide. The marketplace provides certain protections for American Indians. One of them is called the special enrollment periods, where members of the federally recognized tribes, including the NCUIH shareholders, they can enroll in coverage through the marketplace throughout the year, not just during that annual open enrollment period. And members may also change plan as often as once a month. The next is a zero cost sharing plan where members of the federally recognized tribes with household income between 100% and 300% of the federal poverty level can enroll in a zero cost sharing plan, which means these consumers won't have to pay out-of-pocket costs such as co-pays, deductibles, coinsurance, and receiving care from any of the Indian healthcare systems in the U.S. or when receiving essential health benefits. Also, in addition, under the zero cost sharing, there's no need for a referral from any of the Indian healthcare system provider to avoid a cost share obligation when receiving the essential benefits through QHP. The other is the limited cost sharing, and this is where members of the federally recognized tribe with household income below 100% and 300% of the federal poverty line can enroll in limited cost sharing plan, which means no copays, deductibles, or coinsurances when receiving care from any of the Indian healthcare providers. So individuals are not exempted from QHP premiums due to being a member of a federal tribe or a ANCSA shareholder. However, they may qualify for APTCs to lower their premiums based on their income. Moving to the next slide. This next two slides, we can just kind of gloss through them, but they basically summarize the special benefits for American Indian consumers I covered in the last slide. So we can jump to slide 38. How to apply. This is just a quick information for you all on where you can go to apply for coverage through the marketplace. And the link is there available for individuals, individuals and family forms are available there. When to enroll, eligible consumers can enroll in or change marketplace during the annual enrollment. But as I covered, the exception, there's an exception for members of the federally recognized tribe that we can enroll in the marketplace or change plans throughout the year, not just during that yearly open enrollment period or during a special enrollment period. So in the federally facilitated marketplaces for individuals and families, open enrollment starts on November 1st and then it ends in January 15th. The shop marketplaces, this is for determining eligibility for small employers, determine their group annual OEPs for themselves and their employees and dependents. And then small employers can generally complete a small group enrollment at any point throughout the year. The next slide really focuses on streamlining applications. So when you visit the marketplace, you're able to submit one application that allows you to determine if you're able to receive Medicaid or eligible for Medicaid and CHIP in addition to choosing a healthcare plan, all based on your income. So may be able to enroll immediately once your eligibility is determined. And again, you can apply for Medicaid and CHIP at any time. And the website is also available there for you. I will note that within the application process, there is a question that asks specifically, are you or is anyone in your family American Indian or Alaskan Native? If so, the applicant is instructed to go to Appendix B. So if we go to Appendix B, information is requested to assure that the cost sharing exemptions that I've mentioned earlier in income and resources are counted properly for American Indians. It also inquires individuals' relationship with Indian health care system and providers. If you go to, for example, IHS, do you go to a 638 facility or are you going to a urban Indian health center? That sort of question. Ask us about American Indian income, your income and resources that are accountable for the marketplace, but not accountable for Medicaid. Okay. I'm going to switch a little bit, and the information I covered is really going to be beneficial for those that work at the UIO to basically understand what the marketplace is, what the processes are, and how to help our patients and clients enroll into the marketplace and see if they qualify for any of those different kinds of programs and plans available. This particular slide really, slide 43, is the certified application counselor designation thank you. Designated organization. It invites new applicant organizations who want to become a CDO, which is the Counselor Designated Organization for Plan 2024, applying for CMS's open season, and that is launched August 1st through December 15th. The website is here for you to apply and to determine if your application could be accepted and you become a deemed organization to provide assistance to the clients and patients that you serve. Further information, as far as Marketplace also encourages in-person assisters, provide face-to-face, one-on-one assistance for and enrollees submitting Marketplace eligibility application in their federal facilitated Marketplace service area. The Marketplace approved in-person help is available through several programs to help consumers of applying and enrolling, including they help. So if you have any of these types of employees, titles, workers, or workforce in your urban Indian health organizations, you are welcome to call their helpline and ask any questions so that you can help your clientele and your patients apply for coverage. And these are navigators, certified application counselors, agents, or brokers. Okay. The next set of slides are just some basic information, more information as far as the call center. The phone number is listed there. They help with eligibility, enrollment, and referrals. So we could go into the next slide. These next two slides, reducing gap coverage, Rori did a wonderful job providing some recommendations on making sure that we institute best practices in working with the state, tribal nations, CMS, IHS, and our community. Next slide. Rori also covered this slide already, so if we could go into the final slide deck, that would be wonderful. I listed out some additional recommendations that I thought would be helpful to urban Indian health organizations, and that's basically to encourage your facilities to become a certified application counselor designated organization. And if you don't have the capability at the moment, really trying to encourage your staff to train your workforce on the Marketplace, or even to increase staff awareness onto where to refer clients and patients for enrollment, phone numbers, call center information, that sort of thing. Create welcoming spaces to help clients and patients enroll in the Marketplace. For example, in the healthcare setting, you might put up a computer station with internet access and portals, and making sure that you have staff available to assist in that process. Create internal workflows where each of your client or patient is asked to sign up for coverage through the Marketplace at the point of entry at the patient registration desk. Okay. Rori also shared earlier in the presentation, as simple as our phone numbers and addresses, if they're not updated, the state can disenroll. So making sure that all of those key information are up to date is really vital and important. That we create educational, informational and marketing tools which help our clients and our patient population understand the Marketplace and coverages. If this means using indigenous, things that we as indigenous people connect to, pictures, signs that are simplified, it's really important that we're able to connect to our audience. Again, just to reiterate, to partner with our state, tribal nations, health departments to speak and really begin to speak that common language in promoting and signing up our patient and client population. Also, really being a part of the community, whether it's at the health fair, local powwow, or other community events, and volunteering to present at a community event to the population you serve about the Marketplace. Make it a part of your healthcare organization's culture, right? To train all of our healthcare workforce about the marketplace and present to other partner organizations on how your healthcare facility promotes, educates, helps to sign up client patients in the marketplace. Also really working with these partner organizations at your local level to create referral and coordination systems to enroll patients onto the program. So I will hand it back over to Mary. The additional slides you see on your screen are really resources, and they will be included with the slide deck. Due to time, I'll hand it back over to Mary. Thank you.
Thanks, Evie, for that informative presentation.